interested in the connection between all of these different viewpoints about how AI impacts UX and how UX improves technical experiences and all of the above. A reminder to everyone, use the Q&A to ask questions, and I'll be monitoring that, and we'll answer those questions as they come up. Actually, we'll answer those after the talk. Great. All right, I'm going to stop sharing and pass the baton to Brad.
All right. Well, thank you, Margaret. Yeah, so we'll go ahead and get started here. Good to see everyone back from lunch. I'll try to keep everyone engaged and awake after having a meal, and as we sit here on a snowy day in Minneapolis. But as Margaret said, I'm going to take a slightly different tact. So this is healthcare again, but looking at it more from a patient perspective. And I want to start with a story. So a number of years ago, before I actually started working at Medtronic, I was a consultant, as a design consultant, and I was working with Medtronic Diabetes. And they had invited us out for one of their events to learn more about their plans. And one of the things that is very common at Medtronic is this patient testimonial. And so bringing patients in to talk about what their journey was like. And while I was there at Medtronic Diabetes, they brought out this young family with their young son, and they talked about their journey and their young, healthy son. And suddenly one day, with no warning, he was having seizures. And it was obviously, as a parent, incredibly scary. And the child was then diagnosed with juvenile diabetes. And they talked about their journey to finding this new normal. How do you manage blood sugars? How do you test for blood sugars? What do you do with the insulin? How do you administer the insulin? And the parents learning, they also had to teach their son. They have to sort of work to make him self-sufficient as well. And so it's this entire journey that they went through that was pretty scary. The parents were always concerned that their child was going to fall into one of these low blood sugar conditions and have seizures again, or possibly go into a coma. And so they weren't even sleeping at night. They were taking shifts to get up in the middle of the night and check their son's blood sugars. So it really struck me. It really struck me, as a user experience professional, how can we engage with this? How can we make this better? And what really struck me was another slide that somebody showed, which was of this young boy with his insulin pump, and his parents had even gone as far as getting tattoos of the insulin pump with the phrase "forever linked." And it really is the beginning of a journey with a chronic condition like type 1 diabetes, where this is your journey for the rest of your life. And as a child with parents, you're not going through it alone. And so these caregivers and the patient, it's their shared journey. And it's something that, we want this to be as good a journey as possible, right? With good outcomes and good quality of life. So since then, I've actually joined Medtronic. So I'm actually not in the diabetes group, but I work here in the Twin Cities in the cardiac rhythm management group. And one of the great things about working for a company like Medtronic, a large medical device company, is you can make a real impact. So as you can see here, this quote, "Medtronic therapies improve the lives of more than 2 people every second." So that's a really, really broad impact and something that can be really, really rewarding. So a lot of the work that we do and a lot of the conditions we treat at Medtronic are chronic conditions, right? These ongoing conditions that people have to deal with. for long periods of time. At our group, it's cardiac conditions, and our products are things like pacemakers, defibrillators, diagnostic devices, but the company as a whole treats a lot more chronic conditions than that. So the impact of chronic disease is huge. So not only is it the well-being of the patients, right, and their quality of life, which is key, but if we look at it just from economic terms, if you calculate the total costs of chronic disease, so not just the healthcare costs, but lost productivity, lost time at work, it's actually equivalent to about 1/5 of the US economy. So it's a massive, massive expense. 6 in 10 adults have a chronic disease, and 4 in 10 adults in the US have 2 or more. So when we're working with cardiac patients, it's not uncommon for them to also have diabetes. And so we need to think about the patient as a whole and look at these comorbidities, these conditions that occur at the same time, and are there ways we can better treat the whole patient. A big part of chronic disease has to do with lifestyle, with behaviors, right? So if you look at what the CDC calls out as lifestyle risks for chronic disease, it's things that you'd be aware of, right? Things like tobacco use, poor nutrition, lack of physical activity, excessive alcohol use. So as user experience professionals, the challenge for us is how might we encourage and support behaviors that help people either avoid or manage chronic disease and improve their quality of life. So what I think is kind of exciting about this, or interesting about this, is it isn't just a pharmaceutical, it isn't just an implanted device. It's actually supporting the patient on their journey and helping them be part of that healthcare journey and impact their chronic condition. So when we look at what we've talked about a lot today, there's a lot of interesting new enabling technologies, right? So if we look at smartphones and smartwatches, these are mobile connected sensor platforms. They are full of sensors. And because we keep these smartphones with us all the time, if you're like me, your phone is an arm's length away most of the day, and in my case, through the night, right? So there's this opportunity to really gather a lot of rich behavioral information. And because of the connectivity and the user interfaces, you can make it available to both patients and healthcare providers. The problem is, or the challenge is, healthcare providers are overwhelmed. So Andrew was talking about this, and in fact, he quoted the same statistic here, the same number. Doctors are spending about half of their time every day reviewing and entering data. So, like Andrew was talking about, they're spending a lot of time in their EMR, and that isn't really where they want to spend time. And so companies like Andrew's are working on making that process better and more efficient, right? They're only spending about 1/3 of their time with patients. And if you spent time interviewing doctors, nurses, and talking with them, it's really clear that's where they want to spend their time. They want to spend their time caring for patients. And it's difficult when the data burden is such. And it's massive amounts of data. So hospitals, this statistic blew my mind, are producing 50 petabytes of data a year. And a petabyte, that means it's actually 50 million gigabytes of data every year is being produced by hospitals. So it isn't that we need more data, we need a better way to manage it. So if you look at this analysis, this was some analysis done by Accenture in 2017. What they're suggesting is about 30% of physician capacity can be moved to patients, to a smart technology, or a combination. So here's where some of our opportunity is, right? How do we apply these smart technologies? So some of the things that Andrew and his company are doing, but other opportunities as well, but also moving some of the healthcare to the patient themselves, or a combination of the two. So they actually, in this study, charted out supply and demand. So clinician supply and demand, in this case without AI. And in this scenario that they map out, supply never catches up with demand, right? Demand outpaces supply. And so the hope is, with AI, with some of these smart technologies, we can change that slope, bend that curve, and at some point catch up so that clinicians are able to spend more time with patients, spend more time getting care, or caring for more patients, or improving the quality of care across all patients. So this is kind of the opportunity, right? So when we look broadly at how we can kind of gather data from patients across the population to help healthcare systems kind of anticipate demand or plan, this was something that was interesting. Some of you may remember Google Flu Trends. So this was in 2008. It was some research that was done where they were looking at search terms around common symptoms for the flu, and they were seeing that they could predict flu outbreaks about 2 weeks before the CDC. And this is what they're calling like crowdsourced intelligence or collective intelligence, right? You're using the intelligence of this population to help understand where things are happening. But what was interesting, in 2013, this broke because the algorithm really struggled with H1N1, because H1N1 was in the news so much. People were searching symptoms out of curiosity or fear. So just because they were searching it didn't mean they were experiencing the symptoms. So that that relationship that they were counting on, that correlation wasn't there anymore. But still kind of interesting to look at this data. So here, this chart's actually searches on loss of smell. So this is, of course, is related to COVID. And they were seeing some correlation between searches for loss of smell and outbreaks. But in hindsight, or more from a research perspective, or as they're learning more about the disease, they found it helpful because they were able to see that searches for loss of smell actually mapped really closely to like the first outbreak in Italy, for example. So really good at, or it's giving them some information on how to understand symptom patterns. I don't know if you remember, but loss of smell was one of those that wasn't identified initially, right? The easier ones are things like cough and temperature. So again, some interesting insight from this type of intelligence. The other one that was kind of interesting recently was, and you may have seen this as well, there was this Kinza health weather. You were seeing it a lot on the news earlier. So these Kinza connected smart thermometers, I was surprised the amount of data they actually were able to gather. I had no idea there were this many of these smart thermometers out in the country, but over some period of time, and I don't recall the exact time period, it was almost 15 million body temperature readings from 650,000 unique individuals. So with that information, they were able to look at where there were increased body temperatures around the country being measured. So they weren't looking for this kind of second order. They were actually measuring the symptom with the thermometer. And it did show some predictive value, right? It was able to predict where some outbreaks might be coming. So there are places where I think it's interesting to look at how patients or individuals or caregivers can provide data across the population to help healthcare systems understand what demand there's going to be. But what I think we most want to talk about today is, how do we engage individual patients and caregivers, right? Everyone was unique. So how do you get to more individualized healthcare, and how can some of these new technologies help with that? So the reality of it is, individual health stories are very complicated, right? So this is I think a really great diagram. So we're all aware of user journeys, right? And I would say this is sort of a form of a user journey. It's actually a patient journey that was done by Katie McCurdy. Um, and different from most of the user journeys we do, this is a user journey over a lifetime. So this particular user journey starts in 1966 and runs to 2020. So providing a framework for all these events that might have happened in somebody's life. So injuries or significant events, diagnoses, procedures and tests, treatments. And it's a framework that helps structure some of the complexity and interplay, and particularly with complex conditions, there could be interplay that isn't initially obvious. And so this visualization could be really, really interesting. Something I've been interested in is a branch of medicine called narrative medicine or narrative healthcare, looking at the use of the structure of a story or a narrative to help create this framework to hang things like diagnoses, injuries off of that, to help patients communicate their story to their care provider, to their doctor, right? So that doctor could look at this with the patient, start to see patterns, start to dig deeper, start to see where there might be opportunities. But as humans, like, how do we perceive or see information on here that could lead us to take action, right? It's difficult to see interrelationships between a lot of these different events, but that's the reality of our health and our healthcare, right? So if we think of it from an interaction perspective, and this diagram I love. So this is Bill Verplank. He was one of the early interaction design sort of practitioners, and he's always drawing these sketches that I love. So this is his model for interaction design. So as humans, we feel something, we know something, it builds our knowledge, and then we do something. So if you come from more of a human factors background, you would say this is perception, cognition, action, right? So as designers thinking about interactions, like, what information, what context needs to be there? How do we present information so that when it's perceived or felt, we create the right knowledge for the user, the human, so that then they can take actions, right? They can do things. So that's our space, right? That's where we play. And in this particular space, the data alone often isn't enough, right? So sensors can gather a lot of data, but what do I do with it? So me as a patient, I might want my data, but here's my data. Here's my 12 lead ECG from my heart. And then what do I learn from this? What do I know? What action would I take? Now, an electrophysiologist or a trained nurse would look at this, and they have the context and the knowledge to turn this into the knowledge that this patient is having atrial fibrillation or AFib. So the top chambers of their heart have a chaotic, irregular beat to them. And patients with atrial fibrillation or AFib, they're at a higher risk for stroke. So I as a doctor would see this, and I could look at this information and go, yeah, we want to put this patient on anticoagulants, or we want to consider having them come in and we'll do an ablation in their heart to see if we can treat this. But I can't do that as a patient. So how do we engage the patient? We can't do it with just the data, right? So machine learning is something that you've probably heard about or may have heard about. It's one of the kind of common approaches to artificial intelligence. And machine learning, the way it basically works is you take large amounts of data, right? Big data, and then you run algorithms to see if you can find patterns or relationships between different pieces of data or different data sets, right? So this is the process that powers things like recommendation systems in Netflix, search engines like Google, social media feeds like Twitter, voice assistants like Siri, right? And the basic process is look at this big amount of data, find the patterns, and then once you find these patterns, you can apply them to individuals, you can apply it. So in a very particular case here, if you've seen this Cardia mobile consumer device, with this peripheral, you can put your fingers on the two pads and see your heart ECG, right? Your heart's waveform on your smartphone. But unlike the previous example, they actually have analysis in there that's been cleared by the FDA that can say something like this. So if I'm the same patient, it might say possible atrial fibrillation, right? So that gives me a piece of information, but my action would probably be, I'm going to call my doctor with this, right? That is potentially a good thing, but it isn't necessarily handling the burden. But I think what this could be considered for, and some doctors are starting to do, is patients with known atrial fibrillation, they can give them a device like this to help them manage their condition, right? So if you see possible atrial fibrillation over the course of a day, over the course of 2 days, call the clinic, we want to take a look at it, right? And so that would be a way to help the patient be engaged in their care by turning the data into something that was more actionable. So one of the things that's interesting about machine learning is sometimes it finds patterns that we wouldn't find as humans, right? Because it's looking at these really large data sets and making connections that we may not make or see, right? And so this is actually fascinating to me. So there's actually a study that was going on at MIT where they were having subjects do a forced cough into a smartphone microphone, record that cough, run it through an AI model, a machine learning model that I think was for speech recognition. And then from that, they actually were able to show really good performance, or pretty good performance, that they could identify patients or people, users, subjects that were asymptomatic COVID. So the cough would indicate if they had COVID before they even had symptoms. And the numbers here, it was, high 90s sensitivity, 98% sensitivity. So that's just crazy, right? You wouldn't expect things like this to happen. So opens up a lot of really interesting opportunities. The flip side of it is sometimes the patterns that it finds, they're only as good as the data that you put into it, right? So one of the earlier presentations today talked about the risk of AI being biased, right? And so this was from a patient care perspective. This was a study that was published in Science. And so there was this major healthcare risk algorithm, and what they had done and what they had fed into the AI algorithm was health costs. And they were using health costs as a proxy for health needs. And at first blush, you might think that makes sense, right? Patients where we're spending more money are probably sicker. But the reality of it is in the world is that unequal access to care means we spend less money caring for Black patients than we do for white patients. So because that proxy was in place between costs and needs, the algorithm would conclude that Black patients are healthier than equally sick white patients because we're spending less money on them. And it was a pretty big disparity. So the disparity was actually such that if you would eliminate the disparity, the percentage of Black patients receiving additional health would go from about 18% to over 46%. So cautionary tale. The algorithm and the AI is only as good as the training. It's only as good as the structure. It's only as good as the data. So always important to confirm that it's doing what we think it should be doing. So when we were talking about the cough, the COVID cough, that would be something that's diagnostic, right? It tells you a little bit in advance, but it tells you something is happening. It's a detection algorithm. But where it starts to get even more interesting is when we look at predictive algorithms. So a number of companies and researchers, at least, are working on fall prediction, for example. So instead of just detecting a fall, which some models of Apple Watches will do, right? They have a function in them where if it senses a very hard fall, it will try to get you to respond to it. And if you don't respond, it will call 911 for you. And that's super cool, super powerful. But for an elderly patient, falls can be catastrophic. So detecting a fall and getting help, right? It's sort of a modern version of I've fallen and I can't get up. That's valuable. But are there ways we can actually predict if somebody's more likely to fall? And so you look at the type of data that these researchers are pulling in. So they're looking at the heart ECG, the EMG, which is the electrical signals in the muscles, right? Sort of the physiology side of things, and then the kinematic side of things. How are the people work? How is the individual moving? Are they, having almost falls and catching themselves? Are they not lifting their foot as high? And with this, we could do things to maybe have interventions that would prevent some of these really catastrophic falls. So it's a really interesting place to start looking. So want to look at a couple of chronic conditions. So the first is heart failure. So this is one at cardiac rhythm management where I work now. This is one of the conditions that we work with. And so heart failure is this chronic progressive condition. And it's essentially when the heart muscle isn't able to pump enough blood for the needs of the body. So not enough blood, not enough oxygen going through the body. So, and that can either be because the heart muscle just can't pump strongly enough anymore, or the heart can't fill fully anymore. And so with each pump, you're only pumping a fraction of the blood that's needed. In either case, the body starts to compensate, right? So blood pressure starts to change. Kidneys start to function less well. And that means heart failure patients have a tendency to take on fluid. And so they'll have fluids in their body that can lead to hospitalization, can cause a lot of problems, right? And so one of the algorithms that we introduced more recently is something called Triage HF. So all of our implanted cardiac devices, our pacemakers, defibrillators, diagnostic devices, our current portfolio is all Bluetooth connected, and that's fairly recent. Those Bluetooth connected devices send key information either through a smartphone app or a home monitor up to the clinic that's monitoring the patient, so they can see these key kind of clinical parameters and understand if they need to bring the patient in for care. So we've done remote monitoring for many years. Bluetooth is new, remote monitoring isn't. With COVID, I was just talking to Margaret about this, we're seeing even more adoption, that the clinics are bringing in patients less now, and they're really depending on this remote monitoring capability to care for their patients. So, so with heart failure patients, this Triage HF algorithm, it actually tells clinics which of their patients are at the highest risk of hospitalization in the next 30 days. So it predicts which patients are most likely to need to go to the hospital in the next 30 days. And it does that by bringing in these different clinical parameters. Some of them are, around the heart. One of them that's interesting is these devices, the heart failure devices that we have, actually have a way to measure fluid retention in the chest. And with that information, we give the clinics a risk score, high, medium, or low. And if you have a patient with a high risk score, they're 10 times more likely to be hospitalized in the next 30 days. So really interesting information that can allow for smaller interventions now to hopefully keep them out of the hospital, which is a big, miserable, painful, stressful, at least, intervention. So question is, how do you do that with a heart failure patient? And so part of treatment for heart failure for some patients is getting one of these devices, which are rather complex pacemakers that help the heart pump a lot more efficiently, right? And so that more blood can get through the body. But the other thing we need them to do is take their meds, and then diet is a big piece. So they have to really watch their sodium, and because sodium will lead to more fluid retention, which is a problem for these patients. But we all know times where we know the right thing to do, but we don't do it, right? And so we can't begrudge a heart failure patient when their whole family is going out and they want to be with the family, and the family's going out to a Chinese buffet and they love Chinese food. And just this one time, I'm going to have this high sodium Chinese food. And along with a few other things, that may lead to decompensation. So it's really hard. How do we support these more positive behaviors so they can help manage their health? So let's look at behavior design. So some of you may be familiar with BJ Fogg. He's a professor at Stanford that does a lot of work around behavior design. And his most famous model, I'm not really going to talk about, but he's got this model, which is here stated on the left, which is behavior happens when you have motivation and ability and a prompt at the same time, right? The person is motivated to do an action, they're able to do the action, and they're prompted to do the action. So us as designers, right, the prompt part, when we're doing digital stuff, there are ways we can prompt users to things. Ability is about making the task easier, making the behavior easier, so that when something is easier to do, less motivation is required, right? So for us, a lot of it's really usability, fitting their world, making that behavior easy. So I had a problem with my Adobe fonts this morning, and I see it's biting me here. So that was an unwelcome surprise, huh?
They look fine from here. Still legible.
Yeah, except for the one down there on the lower right. So, so if you look at a framework for a behavior, right? The way Professor Fogg breaks this up is he talks about the pieces of a behavior. So it's the persona, the person, the user, their beliefs, their desires, their abilities, right? The action itself, and then the context in which the behavior occurs, right? So the environment, the social context, and the tools. So that word down there is context. So what are the levers we can pull? And it's kind of interesting to think about it this way, right? So for the person, the persona, the user, we can help them with skills, right? We can help them become more skilled in something by providing them information, by training them. The action itself, we can make it smaller and we can help them start. So making it smaller means you need less motivation, right? And helping them start would be that prompt. And then context, we can provide tools within the context to support the behavior. And behavior is a big deal. Within cardiology, they actually can show with studies relationship between behaviors and clinical outcomes, like really clear. relationship. So this paper is actually really interesting. They actually go through these risk factors here on the left, and they show studies. It's kind of a survey of different studies that were done. Even things like lack of purpose. So they had a measure of a person's sort of lack of purpose or lack of purpose. And individuals with low or with a high lack of purpose, right? They have a lack of purpose. Their mortality rates are much worse. And it goes for all of these, right? We would expect things like smoking, poor diet, lack of sleep, right? Depression, anxiety. Those have big impacts on heart health. So on the right, there's a lot of opportunities there for us to think about as user experience designers. How do we treat the whole patient? So I want to shift back to diabetes a little bit. So we started talking about diabetes, and so most of you are probably familiar with diabetes, but the goal for treatment of diabetes is to control your blood sugar level within a range, right? It doesn't get too high, doesn't get too low. And depending on whether you're type 1, which means you don't create your own insulin, or type 2, where you are deficient in insulin, there are medications, in one case insulin, now there's other non-insulin medications, but there's also these behavioral components as well, right? Exercise, weight reduction, and dietary changes, right? So dietary management's a big part of diabetes as well. So thinking back to those parents at the beginning that couldn't sleep at night because they were terrified their child's blood sugar was going to go low overnight, there are actually a lot of innovations happened in that space since then. So today, there are actually glucose sensors that the patient can wear, and those connect to an insulin pump. So on the left there, on the belly, is a glucose sensor, and then on the right is the pump that pumps insulin. And one of the newest insulin pumps that we have actually has this suspension of insulin delivery. So it's not fully closed loop, but if it predicts that the patient is going to go into a low sugar condition, it will stop pumping insulin, it'll suspend insulin. And so this is the kind of thing, as a parent of a juvenile diabetic, or just as a person dealing with diabetes, you have some additional confidence that when you go to sleep at night, you're not going to go into one of these really dangerous low blood sugar conditions, because the system has sensors and some algorithms that will help. But the Medtronic Diabetes Group has gone even further with this, right? So this connected glucose sensor actually can connect to apps on the phone as well. And one of the things they've done, which I think is really interesting, is they have this app called Sugar IQ that uses Watson, IBM Watson, which you may be familiar with, which is an AI platform. And it provides insights like, here are patterns. So again, talking about machine learning and patterns, here's a pattern that I've seen. Watson has seen, right? And tell the patient, here's something to be aware of. Here's a pattern I found that maybe you're not aware of. But it also can predict, again, this predictive piece, predict low blood sugar levels. So allow the patient to make adjustments to their diet or insulin levels long before they go out of range, right? So let's think about that behavior model that I was talking about earlier. They've actually hit on these different opportunities, right? So from a skills perspective, Sugar IQ is an app that actually has a chatbot interface with IBM Watson. So the user can ask questions and Watson will respond. It will also provide opportunities. Here's a pattern I've noticed. Here's where you're doing really well. Here's an opportunity to improve. So helping them build skills to manage their diabetes better. And then under the make smaller or help start, this is the predictive piece of it. So they have an app or a system called IQcast, which is predicting low blood sugar levels and prompting the patient early to make adjustments. So predictive, like the fall prediction or the heart failure hospitalization prediction. So you can make smaller, earlier adjustments. And then as far as tools, there's a tool called Glycemic Assist. And so this is a mobile tool that you, on your smartphone, you have with you. So if you're out to eat, it's a tool that allows you to see the dietary information and inform your dietary choices right there. So a tool to help with those choices and help you manage your diabetes with dietary choice. So, and then the question is, does it work, right? And it's promising, right? It looks really good. So this was a study that was presented a year or two ago. It's helping, right? So they've seen that patients that use the Sugar IQ app, they're spending 4% time more in range every day. And that doesn't seem like a lot, but that's an hour a day better that they're spending time in range. And for long-term outcome and long-term care for diabetes, staying in range is key. And so just with that one intervention, 4% better, that's great. And then the Glycemic Assist tool adds another 4% on top of that. So 8% total additional time in range. So starts to move the needle. So it's a really great example of AI providing insight, providing additional information, turning data into something that's actionable. And then as user experience professionals, how do we turn that into an interaction with the patient that can impact their behavior and impact their chronic condition? So this is an exciting time, right? This is a time for us to think about how we can engage patients and their caregivers in their healthcare and help manage this burden of the healthcare system that we were talking about. Turning data into knowledge, right? So using AI, but also things like good data visualization where that's appropriate as well, right? And then support behaviors that help them manage their chronic condition and ultimately improve their quality of life. So that is it. So if you have more questions, feel free to reach out to me on LinkedIn, or Margaret, if there are questions now, I'd be happy to take any of them.
I haven't seen anything come through on the Q&A, but this was absolutely fascinating. I actually have a question for you.
Okay,
I'll just tee it up. How about that?
that's great.
Please, everyone, if you do have any questions on this topic, just put it in the Q&A and we'll deliver it. We have about 15 minutes to talk. I'm wondering about, there's a lot of mobile apps.
Mhm.
Do you also deliver this information via web or web app?
Sure, sure.
Yeah.
Well, which are you talking about? I mean, I think that is ultimately what we want to be able to do. Our patients tend to be older, right? So
Right.
cardiac patients tend to, well, and you work in the same space, so you know this, right? They tend to be older and they don't all have smartphones. Penetration's getting fairly high, but I think it would be important to reach them wherever they can be reached. And so if that's on the web, certainly we should have that ability as well.
Yeah, I wanted to highlight that only because of the topic, everywhere. And with that lens, I guess I've seen that in the work that I'm doing, very similar to the work you do. That is,
Sure.
The reach has to be multi-platform and device independent.
Right. Yeah, absolutely. What we do find with some of the things we're doing, which have to do with like Bluetooth connectivity or connectivity to these sensors, those need to be apps, right?
Yeah, absolutely. And actually, so we have two questions that hit right on that. Do you run into problems with generational differences in comfort with phone apps? Right there.
Absolutely. Yeah. But you'd be surprised. It's changing constantly. So I've been at Medtronic for 5 years. I've been working on apps there that long, probably. And even just in those 5 years, that you see more and more, right? The people that were 65 years ago are 65 now, and maybe they have a pacemaker. So it's changing quickly. It isn't the case that, oh, none of these older people can use their phones. That's absolutely not true. There are some that are very good with their phones. Many of them are competent with their phones, but they get a lot of support from like family. So family will do things like set up the phone for them and kind of optimize it for them. And then they have their tasks. So they're not digging down into the preferences and turning on dark mode and doing all this stuff, but they can use their phone. Um, because not everyone can afford a smartphone or wants a smartphone or can use a smartphone, we have home monitor options as well that are just plug and play, basically. But those don't follow them through the day.
Yeah, the jitterbug motif.
Yeah.
Well, here's another question for you. When working on the UI for accompanying apps, do you work with the designers who designed the device itself?
So like I assume that means the like the pacemaker or the pumps or those types of things. I can't tell you exactly how it happens in diabetes, but I know that whole design team was together. So when I was working with them, that was under one set of design leadership, and it was one group. And so they were trying to make that a unified experience, which I think is really cool, really important. With our devices that are implants, the patient can't, there's no interaction with the device, right? They can feel it in their chest, but they can't see it or do anything with it. So that tends to be real low-level software that's interacting between the kind of pacemaker designers and the app. But
that gets back into the clinician, the physician being able to interact with it, but not the patient. Yeah.
Yeah, and what we didn't talk about here is we also have apps that are used by the clinicians or our field techs to talk to the devices and program them. And that's a very, very different interface, and that's very technical and getting down into kind of the nitty gritty of programming the device for the specific patient. And we didn't talk about any of that.
Excellent. Here's another one. I think this one's really interesting. How do you think Bluetooth radio waves in devices will affect the human body?
Right? Good question. Yeah, it's 2.4 gigahertz, right? It's the same as your microwave. It's the same as a lot of things in the world. So we're flooded with that radiation all the time in our lives, right? And so I'm not saying that to say it's good. I know that there was, when they were in development of these Bluetooth connected devices, there was a lot of work that went into that. Like we have to demonstrate that these devices are safe and effective, right? And part of safety is making sure that the radio waves aren't going to cause problems. And our devices have had radios in them for a very long time. Bluetooth's new, but the radios aren't. So I think there would be data on that. So yeah. I'm confident they're very safe, but I understand why people would be concerned with that.
Exactly, and that's interesting because the old pacemakers used to use radio waves, and that's where you had to really be careful in magnetic areas and things like that.
Yeah. They're just different frequencies of radio waves, right?
Yep. Here's another one for you. Are you able to use the data you collect for diabetes and cross-reference with other chronic diseases to see if there are correlations you didn't see or think of?
Right? That's a great question, right? So if earlier in the presentation, I was talking about comorbidities, right? And that is something I think would be very, very interesting, is to look at relationships between sensors that are sensing those different chronic conditions and feeding that in and seeing if changes in insulin are impacting something in heart function, right? I think that would be fascinating.
Yeah, we see some studies trying to tie together those data points,
Right.
but it's very complicated.
Mm-hmm.
Here's one. Some of these tools require knowledge of users' other behaviors, such as what they ate today.
Yeah.
To make it work, are users required to submit relevant information to the tools?
Yes, for some of them, right? And that's with both with heart failure or diabetes. So with heart failure, those patients are asked to monitor their weight because weight changes can indicate fluid intake or fluid retention. With diabetics, it can be diet, right? Diet also with heart failure patients. That's tough. And so that's part of the behavioral piece. How do you get somebody to engage and adopt a tool where they have to manually enter that? And I've seen some early work where they've tried to use machine learning to allow a user to just use a camera and point it at their plate of food, and the plate of, and then the machine learning says, oh, it looks like you're eating chicken tacos and pinto beans and some rice. I don't know how far along those are, but that's clearly an area where if you're thinking about this loop or data that could inform the patient, that's interesting data and could be valuable data, but it has to be manually entered. Now, scales don't have to be manually entered necessarily. They could be done with Bluetooth. But the harder part, I think, is setting up a routine or a behavior or a habit, creating a habit that the patient will habitually every morning get on the scale and weigh themselves. And so there are a lot of things outside of the app that are opportunities. And for us as user experience people is how do we support those types of behaviors?
Yeah, human behavior is really tricky.
It's really hard. Yeah.
Here's one from Yihan. It says, this is fascinating. Would you like to share more on how do UX researchers research the complex psychological aspects of the patients? And what is the state of the art to help people feel better? In like, what can be
Yeah.
done to combat high-level cognition patterns like lack of sense of purpose?
Yeah. Yeah. Awesome question. That is super interesting. So we have an advisor that really so a physician, a doctor who's an advisor to our business that really focuses on the mental well-being of the patient, and that's his background. I think he's a clinical psychologist, and so we've had collaborative sessions with him to try to work through opportunities to help address some of those needs. Those are harder needs to address sometimes. Heart failure patients, and particularly patients that have defibrillators, so devices that when your heart goes into a chaotic rhythm, it shocks it back into rhythm. So like the paddles you see on TV, and they say clear and they shock, we have devices that are implanted that'll shock the heart back into a normal rhythm. That is a super scary, super painful thing. Now it saves your life, but these patients are not surprisingly very anxious about that because they probably got the device when they almost died. And now they have this thing in their chest that at any time when it senses one of those rhythms could shock them. So he has programs with patients, and we try to leverage some of that. And so some of the things we try to think about, and I wouldn't say it's in our systems now, but that would kind of be the approach. And then reaching out to those patients as well. I don't have the perfect answer, but it would be working with professionals in that field. And then I think we would want to go out and actually work with those patients. And we touch patients quite a bit when we're doing research. And I will tell you that a lot of times when you're starting the research and you're kind of going through that phase where you're warming the subject up and getting them comfortable and they start telling their health stories, it can get emotional. It can get really emotional. The patients will start to tear up, and the researchers will start to tear up, and it's legit, right? And I think for us as a goal, as a profession or people working in medical device or healthcare, is how do we use that empathy that you feel to drive solutions that can help those patients on a lot of different levels. It's hard, but it's important.
Yeah, it's so true, that emotional side when you're talking directly to folks with these issues. Here's a very interesting one, and also a shout out to you, Brad. First off,
Yes.
Paul really likes your Fender shrine behind.
Oh.
But his question is, do you see hospitals or physicians employing some sort of data scientist in the future? Who is combing through all of this data?
Yeah, well, we have them, right? So Medtronic, as you can imagine, so like Boston Scientific, where Margaret works, we remotely monitor patients, right? And so there are large databases of that information that data scientists can go through and look at, right? So, and I have seen, I'm not an expert on this, but I have seen sort of stats or listings talking about the need for data scientists in healthcare, because I think also in the world that Andrew's business is living in, right, the EMR, how do you pull insight out of that data? And so there are things like clinical decision support. So there was a question during Andrew's presentation about whether we thought, or he thought, AI would someday be making these kind of clinical decisions, to treat the patient. I think that's a ways off, but what is starting to happen are these clinical support systems, clinical decision support systems that are pulling together insight around these different patterns to say, this appears to be the case and this might be recommended, but it's up to the doctor to make the decision. So I think it's going to be it's all over the place. When you see petabytes of data, certainly you need data scientists to be looking at it.
Petabytes.
Petabytes, yeah.
Somebody posted that's a new word for them. Here's a quick one last quick one.
Yeah.
You're talking about behavioral change, the UX of rewarding good behavior.
Yeah.
It's into gamification.
Yes, absolutely.
So it's how do you and it's probably much longer answer than we probably have time for, but I thought that was an interesting question. How do you do the UX for gamification or reward of behavior?
Yeah, that's a great question, right? Because it can help with motivation. So that's that part of the behavior, is how do you motivate people? And you look at apps like Snapchat, right? And it rewards you for streaks and things like that. When my daughter was younger, her friends would hand off accounts to other friends to keep streaks going while they were on vacation and out of touch, because the streak was so important to them, right? So the gamification was clearly working there.
Right.
So if you look here on that screen on the left, there's a little bit of that here, right? It says, I like this trend. I see that you had 40 fewer nighttime lows this month than last month. That is a great trend. So a little bit of reward. You're doing good. You did better this month. I am not super familiar with Sugar IQ. That's a different business unit, but I suspect it has some of those gamification things baked into it. You can kind of see it there on the
Yeah.
screen.
I had a really interesting bit of work on a diabetes application at Optum, and we had
Mm,
coaching moments that were very
yeah.
challenging to create, only because we didn't want to, become irrelevant or silly. So it was very challenging. Anyway, that is great. We are
Yeah.
at time for Brad. This was amazing.
Oh, thank you.
And I hope everyone enjoyed this. We have one
Yeah. Thank you
more
all.
presentation today. And at 2:15, BJ Yurkovich is going to talk to us about privacy, which has clearly been a burning issue across all of our topics today. So I'm really interested in that. We're going to take a quick break, stretch, get something to drink, and we will rejoin here at right at 2:15. I'm back on just a few minutes beforehand. Thanks again to Brad. What a fabulous presentation.